I'm Dr. Susan DeCenso Brown of the Touro College of Dental Medicine at New York Medical College. In our Smiles United lessons on autistic spectrum disorder and cerebral palsy, we discuss behavioral disorders and disabilities. In this video, we will focus on intellectual disabilities and their oral healthcare implications. Often, disorders are co-occurring. Intellectual disability and language and speech disorders can be associated with several neurodevelopmental and genetic disorders. According to the CDC, intellectual disability is a term used when there are limits to a person's ability to learn at an expected level and function in daily life. Intellectual disability may or may not be present with developmental disabilities such as autistic spectrum disorder and cerebral palsy, genetic disorders such as Down syndrome and Fragile X syndrome or Prader-Willi syndrome, and prenatal injury such as fetal alcohol syndrome disorder, to name a few. It is important to note that many people with intellectual disability can lead independent lives. Depending on the severity of the disability, an individual may require different levels of support for self-care, such as oral home care. Those with mild disability may require minimal support. Moderate disability requires moderate support. Severe disability requires daily support with self-care and safety precautions. And profound disability requires 24-hour support. Each individual presents differently, and this video aims to discuss some common challenges and potential solutions in terms of oral care for individuals with intellectual disabilities. Modifications may be required and are encouraged. Research has shown that individuals with intellectual disabilities have poorer oral health and greater prevalence and severity of gum disease than the general population. Multiple factors contribute to this outcome, some of them directly related to their intellectual disability, including lack of understanding the importance of oral health, difficulty learning and slower to develop daily life activity skills such as toothbrushing and flossing, and difficulty effectively communicating with their needs and preferences. Other factors affecting oral health may be related to co-occurring conditions, medications, and diet. Language and speech disorders can occur on their own or together. According to the CDC, language disorders can include aphasia, which involves difficulty understanding or speaking parts of language, or auditory processing disorders, which involves difficulty understanding the meaning of language. Speech disorders can include difficulty forming specific language or sounds correctly, or difficulty with the flow of words, such as stuttering or stammering. Individuals can also have language delay, whereby they develop speech and language processing more slowly. These conditions can present on their own or in combination. Regardless, an understanding of the individual, their preferences, their disability, and their needs will help the direct support provider know what level of support is required for that individual. For individuals requiring mild to moderate support, strategies discussed in earlier Smiles United videos, such as behavior guidance techniques and autism spectrum disorder and oral home care, can be similarly helpful. For those requiring more significant support, adaptations such as head supports or mouth props discussed in the lesson Troubleshooting Common Oral Hygiene Issues may be needed. Additionally, depending on the level and type of support required, consider 2 direct support providers, or DSPs, for one individual. One DSP can be responsible for physical support, while the second can be responsible for the oral care delivery. As always, communication among the resident, their DSPs, their dentist, and any other support people the resident requests is important in developing an individualized, successful oral home care routine. Despite best efforts, residents may still avoid or resist oral care. There are many possible reasons for noncompliance, including but not limited to fear or anxiety, previous bad experience, behavioral disorders, existing pain, or acute or chronic illness. First, try asking the resident why they do not want to complete their oral care. This can open the conversation to addressing the very specific needs of the individual with opportunity to overcome certain obstacles. If the individual refuses to answer or is unable to answer, determining a plan to overcome obstacles may be more challenging. The overall goal is to develop a successful routine that is also as comfortable for the resident as possible. Additionally, diagnostic overshadowing should be avoided. The Joint Commission defines diagnostic overshadowing as attributing symptoms to an existing diagnosis rather than considering a potential comorbid condition. For example, pain and sensitivity has been cited as discouraging factors in performing oral hygiene. An individual with intellectual disability may refuse oral home care due to oral pain. If they are unable to verbalize this pain, their noncompliance may be attributed incorrectly to their intellectual disability and subsequent behavior without pursuing the source of pain. The pain is not addressed, and oral home care continues to deteriorate, leading to further discomfort and oral disease. In cases of uncertainty, it can help to know the individual's usual behavior. If noncompliance is an unusual behavior for them, consider an assessment by their dentist to rule out an acute oral issue, such as pain or infection. Ruling out pain as a source of noncompliance can be difficult at times. First, look in the mouth for any changes. Consider the common oral diseases discussed in the Smiles United lesson, Basics of Oral Hygiene. If you are providing oral care to a resident, regularly inspect the resident's mouth for signs of dental disease, such as cavities, gum disease, or trauma. If identified, a dentist should be consulted at the earliest opportunity. In many cases, nonverbal signs and cues indicating pain or discomfort can also be observed. Some individuals may develop the following pain signs: grimacing or flinching, stimming, or self-injurious behavior. The individual in pain might also avoid eating certain foods or avoid eating altogether. However, pain signs may not be specific. If you suspect oral pain in a resident who cannot verbalize their discomfort, consult a dentist at the earliest opportunity. Another common challenge is forgetting to perform their oral health care altogether without prompting or support from their direct service provider. To overcome this, it may be helpful to utilize a chart or schedule. This model encourages responsibility and allows the individual to take ownership of this task while simultaneously being reminded. Additionally, allowing easy access to the necessary tools removes hindrances. An example would be having the toothbrush and toothpaste in an easy-to-reach, visible area. The relationship between direct service provider and the individual with a disability has been shown to be an important factor in maintaining good oral health. It is important to show respect to those you are working with and be patient when you are monitoring or providing physical and/or verbal prompting. Good oral health can have profound physical, emotional, and social effects on an individual's life. Thank you for watching this lesson of Smiles United with Touro College of Dental Medicine. Be sure to view our other lessons for more information.